shall be discussing about the development of bone sarcomas and little bit touch base upon desmoid, the evolution care from a lead tertiary care institution in India, Tata Memorial Center, where I belong to, and applicability of these protocols, which are essentially developed in Tata Memorial Center by our team, and how they are applicable in other low middle income countries, including Bangladesh. So that's what is my topic, and we will, in this talk tour, we shall be taking about mainly osteogenic sarcoma, the evolution of care over last 3 decades, in finally culminating to OGS 12, which is our standard of care protocol, and many of you keep connecting to me on these protocols nuances. The desmoid fibromatosis, again, our own indigenous metronomic therapy protocol, which is $130 for an entire year care, in comparison to the gamma secretase inhibitor, which is current in use, and not really affording for large majority of the patients globally. Ewing sarcoma, again, our indigenous protocol, EFT 2001. So these will be my talks. So I'll begin with the osteosarcoma journey, the last 2 decades in India. It's a small steps, big changes model, and it's published in a couple of journals successively, which also I will come. So I will begin, I'm a movie buff, let me be acknowledging this, and I believe that this movie, The Shawshank Redemption, which is the undisputed leader on IMDb's for top 250. Many of you must have watched in olden times this movie, and yeah, so this classic follows Andy during his 19 years of prison life, and what helps him escape the slavery of the Shawshank prison. I always relate this analogy with our osteosarcoma care, and why and how we will discuss in a couple of minutes. So we shall be talking about an orphan disease, osteosarcoma, and how we have evolved in taming this beast at our center in over more than 2 decades journey. So we know that osteosarcoma is the most common primary bone tumor of growing skeleton, although sarcoma per se are rare. And 80 to 90% of all patients with osteosarcoma metastasis develops in the lungs, then in bones, and rarely in lymph nodes, also in other organs. It is essentially a systemic disease, and 75 to 90% of the cases, if there is only amputation or surgery, then 50% of the metastasis develops within 6 to 8 months, and 75 to 90% within a year. After 2 to 2.5 years, if patient is surviving without metastasis, generally there is a flattening of the curve, and these patients become the long-term survivors. We all know this. So in the pre-chemotherapy era, the survival used to be dismal, less than 20%, less than 16%. Generally, osteosarcoma meetings are ended with a condolence that nothing could be made. So truly, the chemotherapy advent is a wonder story in this disease, and the modern treatment schedules normally include combination of adriamycin, cisplatinum, and/or high-dose methotrexate or ifosfamide as a third drug, and the fourth drug as etoposide, and different permutation combination of these protocols have been developed. And you are seeing this jump of the survival comes from less than 20% to more than 60% in in couple of decades when the chemotherapy come into work. However, let me be confessing this, that this was not the story all across the world. In developing world, there was a lot of discrepancy in comparison to the developed world, and this is our own olden times OGS 99 protocol, which is showing a dismal survival. This is 2 decades back, and it is showing really nihilistic outcomes. So there was gross mismatch in low middle income countries, large volumes, resource constraints. That is rampant all over. We all are well aware of these, and we thought that there's an intelligent redistribution of limited resources which is warranted to improve the outcomes. There's nothing which will come from sky. It has to invented and discovered and developed among ourselves, respecting the needs and resources. So adopting smart ways, eliminating inefficient and expensive interventions with limited benefit, that's how we thought we need to work and improve upon. So osteosarcoma protocols mainly utilize the diet backbone of cisplatin and doxorubicin. This is all across American, European care systems. This is the diet backbone which works the best. Addition of a third drug, which can be either high-dose methotrexate or high-dose ifosfamide. This augments efficacy. Again, it has been shown in multiple trials. So high-dose methotrexate, while it is an integral part of therapy, especially in the Western world, it is without the randomized evidence of superiority over non-high-dose methotrexate-based protocols. Moreover, there is costly inpatient administration with mandatory pharmacokinetic, very stringent monitoring, very stringent hydration control, which all poses a real challenge for its use in low middle income countries. That was our realization, and while we know the outcomes of the standard high-dose methotrexate-based protocols like Euromos, etc., we do not know the outcomes of modified high-dose methotrexate-based protocols, which is more often a norm when we see patients. Then they have been the dose augmented, dose is reduced. They have not maintained the dose density, which is ideally should be weekly administrations, weekly basis. The dose density intensity must be maintained. This is not being practiced because of various reasons: high turnover hospitals, limitation of bed, patients limitation, resources, and also the not having stringent hydration control, which is the norm, which is very much required. If you overhydrate, you will dilute the concentration, the peak concentration, which is very important for osteosarcoma care. If you underhydrate, you will develop toxicities. Similarly, leucovorin rescue, which again needs to be stringently given in the required dosages. Many times we see, to avoid toxicities, there is dose reduction, there is more space between the cycles, and also more leucovorin which is being administered, which again all dilute the outcomes. We don't know the outcome of, because it's never published. So we don't know the outcomes of those modified interventions with high-dose methotrexate. So these are the various prospective studies from all across the world which has shown the equivalent outcome of non-high-dose methotrexate versus high-dose methotrexate-based therapies. Although because of being rarity, the randomized trials are difficult. The randomized trials is only in the form of the 2-drug versus 3-drug, the European protocols, which again shown the 2-drug was found to be superior to the complicated high-dose methotrexate-based regimens, but there are criticism to that trial. So again, nothing can be concretely said. Even in Cochrane review, it is admitted that we don't have evidence at present to use one over the other. These are the guideline statements which again said the 2-drug diet backbone over and above a 3rd drug, which is fine, NCCN or ESMO. So this is the ESMO guidelines, and me and Aisha both were part of these guidelines in ESMO, and again it is kind of divided for pediatric versus adults. So in pediatric, still high-dose methotrexate is a custom and convention all across the world, but in adult, everybody felt that high-dose methotrexate giving is a challenge, and perhaps non-high-dose methotrexate-based therapies can be utilized. In our part of the world, even for pediatric and adolescent, we need to be very cognizant whether we are able to give high-dose methotrexate the way it is developed and prescribed. Otherwise, the other 3-drug regimen is also an acceptable norm. So background of developing the low-cost OGS-12 protocol, that these labor-intensive high-dose methotrexate administration, which I just mentioned, stringency regarding hydration, the leucovorin, the admissions, the complex monitoring, these are fueled intense research into non-high-dose methotrexate-based therapies. And the result of older protocols at our center was suboptimal with higher toxicity, dose reductions, and delays. So we, in this journey, we actually describes the osteosarcoma care of more than 2 or 3 decades, I would say. And we used 3 sequential non-high-dose methotrexate-based combination chemotherapy protocols over the years and found that what works best and why. So this includes eliminating ineffective drugs based on emerging evidence. We intensify supportive care to improve compliance at our center, which we found very, very important. So we learned from our mistakes. I shown you the first slide that there was in OGS 99 where was the dismal kind of outcomes, and we kind of introspect and in a stepwise manner we tried to improve this care pattern. So first we tried to work on the compliance. What we found that initially our OGS 99 protocol, it was comprises of 4 drugs therapy. So in that the 4th drug was cisplatin, doxorubicin, 3rd drug was ifosfamide, and 4th was etoposide. So it was an intensive protocol. But that time the growth factors were not generic. Growth factors were the Neulastomer. So the original growth factor, which used to be very costly. So we could not administer the universal growth factor prophylaxis to everybody. And then resultant, there was huge dose modifications. So patients were many patients were 50% on 50% dose. There are interruptions, there are delaying, and toxicities. Patients are not coming in time when they are developing febrile neutropenia, septicemia. So all those factors, they were dismal outcome, which I have shown. First, we worked on the chemotherapy compliance part. We thought that we need to give in the manner it is being developed. And fortunately, this time the growth factor becomes generic. And for large majority of the patient, we were able to administer growth factor, and this helped us in tremendously and maintaining dose density aspect of the protocols. So there we comes with OGS enhanced protocol, OGS 99 enhanced, and here with VC we published also that improving compliance is having bearing on outcomes. So sometimes seemingly looking smaller intervention can be really successful. First we improved the compliance, then that time the ENIGMA meta-analysis has come. And this is in 2011. And I would say, especially in these rare diseases, the meta-analysis are extremely important, because doing randomized trial, because by being virtue of rare, it's difficult. So there are many conclusions which we can learn from this meta-analysis. This meta-analysis was very important, and it is shown that the different drugs, among the 4 drugs which were working in osteosarcoma space, they were adriamycin, ifosfamide, and methotrexate. They all have more than 20% activity as a single agent, which is required for a drug to act in a certain space. While etoposide as a single agent only had 4% activity, and when it is added, it increases toxicity. So what we, with learning from these lessons, we dropped etoposide from our protocol first. So we thought that we will use intelligently the 3 most important drugs which are working well. So this ENIGMA meta-analysis has also shown that 2 drugs versus 3 drugs, the 3 drug was found to be better as far as the EFS and OS is concerned, while 4 drug, while added, it only enhanced toxicity and not adding to the outcomes. So the lesson learned, the most important drugs are, the least important is etoposide other way, or most important are cisplatin, doxorubicin, methotrexate, and ifos. And 3 is better than 2, 4 is not better than 2, rather more toxic. So we've taken that we will take 3, what is most feasible in our circumstances. So we've chosen ifos over high dose methotrexate. So this meta-analysis is important as it thrown light on some unanswered question on osteosarcoma. There was practice-changing implications, and we have actually changed our practice, our protocol, and removed etoposide from our multi-drug protocol after confirmation that it is having only a poor activity of around 4%, and reserve it as for salvaging in relapse settings. We made it 4 to 3 drug protocol. Further, we have further worked on we give more pressure on our neurons. We thought that perhaps our protocol needs to be more dose dense. Based on Norton-Simon hypothesis and confirmation from breast cancer therapy, I do breast also incidentally, so this is a combination. Somebody was mentioning initially that there's a rare combination of sarcoma and breast, so I'm also falling into that segment. And we made our protocol more dose dense based on the Norton-Simon hypothesis and confirmation from breast cancer therapy, wherein Milan study has shown that both CMF and doxorubicin treatment were more dense in the sequential arm rather than the alternating. So previously, OGS 99 protocol, they were using alternating regimen. So in one cycle it was cisplatin, doxorubicin, another cycle it was ifos, etoposide. So it was an alternating cycles. While we saw in these breast studies that when we give 4 successive cycles of doxorubicin and 4 successive cycles of CMF, in sequence, that makes the protocol more dose dense. So we changed this alternating sequencing to sequential doublets. And I would say the wisdom is the daughter of experience. And a smart man makes a mistake, learns from it, and never makes the mistake again. But a wise man actually learns from others' mistakes. So we have actually really studied all of the protocols, what is best and what was to drop, and we finally come to a protocol. And also I'm very grateful to the many critics. While we were in the phase of developing this protocol, there were n number of critics who felt that this will never happen or this should not happen. So that also gives us a lot of inspiration. So I think we should value our critics as well. And also I'm very grateful to my mentor, Dr. Banavali, who is a pioneer in medical oncology department, and he is a scientist as well as clinician. And with that, support, we could develop this OGS 12 protocol in our department, which is, which is a simple and can be administered completely on OPD basis, doesn't require a stringent pharmacokinetic monitoring, etc. Ifosfamide based, and it is more dose dense, so similar kind of dose intensity, but because we made it sequential doublets, we increase the density, and that's how we thought that it will work better. And this is our hybrid chemotherapy protocol, taking into account all sorts of good protocols in a world. And it is a sequential doublet cycles of cisplatin doxorubicin for 2 cycles, followed by IFOS dox for 2 cycles, followed by surgery, wherein my efficient colleagues like Prakash and all, they do wonders. And then again 4 cycles of IFOS cisplatin doublets for completing the neoadjuvant surgery and adjuvant. With this, we have shown that our results become matchable to the international standards after this lot of jugglery and lot of work even on tumor kinetics principles. So we are really proud that this is developed indigenously in Tata Memorial, and it worked really good. 2012, this is kind of the story began, and after a preliminary pilot in 11, and then early we published that this is comparable, 3 and 5 year survival to tune of 60%, and now we have even updated result. Majority of the patient completed 5 years, and a good number even 10 years. So that data is under consideration. So I'm not disclosing the result, but it is very promising. And in the tune, what we have seen at little early follow-ups. This has been tested in metastatic setting also, and it also found in metastatic setting it worked equally well. And this is again published in JGU. Then we have, this is the comparison studies of OGS 12 protocol and different other worldwide protocol in non-metastatic and metastatic setting. Both we found comparable survivals. So then we documented this journey of more than 2 decades, that how these small steps make big change. And this is from OGS 99 to OGS 99 enhanced. When we incorporated nutritional support and growth factor and counseling aspect, and then how we reached to OGS 12 with really comparable results. And we're definitely now building on further that how can we enhance from here more. And with peri-operative window of opportunity, etc., as we are trying to work on those things. So this is the 3 protocols, and these are the baseline characteristics. They're largely comparable, but we found that OGS 12 protocol fared really better than all, and even with respect to the febrile neutropenia, because we were giving universal growth factor prophylaxis. We are doing a nutritional assessment at baseline, after post-cycle of neoadjuvant and after adjuvant, administering them what is required in a very aggressive manner. For example, our baseline, lot of our patients, the majority, they are receiving intravenous iron therapies. They are using intravenous injections for vitamin B12, folate, vitamin D. Pre and post cycle, we are doing an audiometry. We are seeing if there is any cisplatin related toxicity which is developing. Additionally, we are doing DTPS GFRs to see their stringent renal reserve. So with all that, we are able to decrease the toxicity. We are able to enhance their outcomes. And this is, I'm showing the comparable to world literature. And this is truly an evolution of care. So that's how this name is. That's a really journey, more than 2 decades what we traveled in our country. And then we were invited to give this resource appropriate selection of osteosarcoma treatment by pediatric blood and cancer. How can we develop this model in other low middle income countries, and where I am here, that this can be really mimicked everywhere. And since it doesn't require admissions, we are delivering completely on daycare basis. This is largely implementable even with limited resources. Of course, universal growth factor prophylaxis is a must, because these are intensive and dose dense protocols, but with the availability of generics, it's largely doable. So this is, I'm really happy that we begin that, and gradually the world is seeing the progress, and they are very generous in adopting in ESMO guidelines, wherein again me and Aisha were also participants. This protocol has been adopted as an alternative of care, and give definitely a reasonably good option. So I would say the conclusion of this osteosarcoma care, that is a simple story, but not really easy to tell, because a lot of hard work, lot of permutation, combination, and different time frame is involved. Addressing inefficiencies is vital to improve care. unless we accept in our mind there are some inefficiencies, we will never be able to improve. And sometimes these seemingly simple practices may significantly impact patient care. The novel economic OGS-12 protocol results in internationally comparable outcomes with ease of administration and is worthy of wider clinical application, including in all low middle income countries, including in Bangladesh and others. So that is what our OGS journey, which was the main focus. Now we'll very briefly touch base upon desmoid fibromatosis, which is again our own work. And there also we are working and we have kind of evolved with metronomic therapy as a low-cost, sustainable standard of care option. We know that desmoid fibromatosis current standard is observation. If patient is not symptomatic, we observe those cases. If patient is symptomatic, generally our patient comes in that stage in Tata Memorial, and also many times they are having recurrences outside. They have given some local treatments, etc. And with that, because local treatment cannot completely eradicate the disease, they generally grow back. So then comes the option of systemic therapies, and all those systemic therapies, there are a couple of systemic therapies options available. There's nothing really well established because of several reasons. Sorafenib is one of the important drugs. Dr. Mrinal Gaundar, who's a close colleague, collaborator, and friend, he did this randomized trial in fibromatosis and found this drug is really working. But again, there is the standard dose, lot of toxicity. The cost is also another issue. The recently approved gamma secretase inhibitor, which is the talk of the town, and again, Dr. Mrinal Gaundar, Dr. Casper, Bernard Casper, both collaborators, and they worked on this protocol. But the unfortunate part is, in the large majority of the world, the cost, which is the current cost, it is not, people cannot afford this. So our protocol, which is comprised of vinblastine, methotrexate, and tamoxifen, in the positive time, I will not go into all the detail, but the therapies on weekly fashion and tamoxifen on daily fashion continues till 1 year, and then tamoxifen further alone for 2 years. And with this, our survivals, our progression-free survivals are definitely comparable to the international literature, whatever being available with other drugs, and with a very low cost. So it is only $130 therapy in an entire year, and this data. So this is one or two patients' pictures, and we can see that the response in the form of MRI signal change, and these patients do well for years, and with a very low cost. This data was presented in CTOS in the Sarcoma of the Year session last. It was selected as an oral, and now it is accepted in JCO, Journal of Global Oncology, with an editorial commentary, because it is such a low-cost therapy wherein entire world can afford this with comparable outcomes. Again, Ewing sarcoma, again, this is our indigenous protocol, EFT 2001. Our very senior people, Dr. CNR and Dr. Banati, they developed way back, and with the help of multidisciplinary team over the years, we again developed and enhanced our supportive care elements like nutrition, growth factors, etc. And again, in this cohort also, we are having comparable outcomes world over. So this one important aspect I would like to emphasize here in all these protocols is that many of our patients, when they reach to our center, they are inadvertently treated in periphery by the people who are not having experiences in sarcoma care. So I want to make this message loud and clear that this practice should be discouraged. We need to do those educational sessions, awareness, everything, so that inadvertent outside treatment should be discouraged. People should be knowing that the first treatment is the best chance of treatment. First planning is the best, planning. And if they inadvertently do something, maybe they do some kind of surgeries, the very, contaminated open biopsies, or some chemotherapies, more often than not, they receive some kind of steroids, some kind of vincristine, etc., and whatever dosages and manner they felt adequate, radiations a little bit, and then months delay, and then they come to us. This window of opportunity is lost in between, and the upstaging further compromises their outcomes. So I urge, and we should, at a national and internationally collaborative level, we should try and see that how can we really decrease this kind of practice. In our osteosarcoma protocol as well as our e-wings, we have shown that this factor was found to be an independent prognosticator for prognosis. So again, a seemingly small intervention which can make a drastic change. People should know when they should not touch or when they should do a timely referral to reference centers. So I think this is my important message here. And again, in geriatric patients, more than 40 years, adult and geriatric also we shown the equivalent outcome of e-wings. I will not go into the detail. I will share all these papers with the team so that they can be circulated and we can be connected. These are some of our work in prognostic sessions. So we found VEGF expression, MRI surrogates, diffusion weighted as well as dynamic contrast, PET-CT based, and chemotherapy compliance very importantly as surrogate markers for ultimate prognosis. Then we are doing collaboration with ASMO as far as the guidelines are concerned for the position papers in rare cancer segment. Again, I'm with a few of our colleagues sitting here. We are doing these all collaborative work, and I think need of the hour is collaboration between all aspects, and we are very happy to help in whichever manner it is possible. And in different segments this is being happening. I want to give up really emphasis on supportive care. I've shown you the supportive care importance as far as the compliance is concerned. Further making to this effort, we are trying to develop how can we decrease our vomitings, and this is our recent work which is now into Lancet Oncology, and it has shown a very seemingly small intervention wherein we decrease the olanzapine. The standard recommendations are to use 10 milligram olanzapine with triple antiemetic therapy. And we see, and you all must be witnessing, especially the medical oncologists, when we give this drug, there is very good control of chemotherapy-induced nausea, vomiting, but the patient keep on sleeping. So their activity, their daytime, doing any kind of work is drastically reduced. So by reducing the dose to 2.5 milligram, we found equal control, non-inferiority, but with very less daytime sleepiness. So again, we can increase the productivity, activity, daily life, time when they can concentrate on their education, work, and they can be more productive. So again, I'm enhancing that we need to work on supportive care elements as far as the possible. So my take homes here is that ours are unique populations and unique challenges. One size does not fit all. Our problems needs our solutions. Low-cost, sustainable care for all matters really a lot in this part of the world, and we must respect and do things for that. Follow-up and quality of life indicators, dedicated clinics, especially for like AYA, geriatrics, survivorship issue, etc. is neat, and they really should be enhanced by collaborative efforts. Community education, avoid inadvertent treatment, early referral to sarcoma reference centers are must. National, continental, international collaborations warranted, and we should do constant efforts in this space. I completely believe that small steps become infantile later on to develop into adolescent phase and then mature adult. So with this, I started with Shawshank Redemption, and it was an ode to hope. The movie indeed is about redemption, and as Andy escapes, you realize how important it is to keep faith and persevere, because you either get busy living or get busy dying. With this, thank you very much for your patience.